My name is Michael Giovingo. I'm the director of the Glaucoma Service for Cook County Health in Chicago. I've been performing MicroPulse TLT for about 6 years right now. Started in 2015. Have been working with the company extensively on the parameters and trying to optimize the equipment as much as possible. And today we're going to be talking about why it has a place in using it before incisional surgery. So a little bit of background, if I can get this to work here. So the laser itself is emitted through the Iridex Cyclo G6 system. It's an 810 nanometer diode laser, which is thermal. Something to take in mind, it is absorbed by melanin, but can also be absorbed by hemoglobin, marking spots, etc. Something to take into account when performing the laser on a patient with a hyphema, vitreous hemorrhage, etc. It was more of a problem early on, but highly don't recommend using marking spots because the absorption can be variable. The machine itself can perform both continuous wave laser and micropulse laser through the MicroPulse P3 probe. The original continuous wave, which I'm sure everybody is extremely familiar with, fires the laser when you depress the foot pedal and continues the power throughout the entire time that you depress it. So if you're setting it for 4,000 milliseconds, you get the exact power that entire time. The MicroPulse itself ramps it up and for a very brief period of time, and then drops it back down throughout the time that you're depressing the foot pedal. Depending on the duty cycle, there's an on and an off phase, allowing for the tissue to be treated, but then not enough time for the thermal energy to hit surrounding tissues, hopefully decreasing collateral damage. Dr. Noecker looked at the pathology of it and actually showed there was a significant decrease in coagulation and necrosis of the ciliary body with MicroPulse in comparison to traditional continuous wave cyclophotocoagulation. This slide is kind of a busy one, but I think it's extremely important. We'll get into it a little bit when we're choosing what patients to use. This is from Dr. Murray Johnstone, who I've had the pleasure to work with on a lot of different things. But he essentially took post-mortem monkey eyes and treated with MicroPulse cyclophotocoagulation. And we can see the video here. Essentially, what we're trying to find out what is occurring. So if there's not ciliary body destruction, how does this laser actually lower the intraocular pressure? And let's see if we can get the video to work. And what we see is scleral shrinkage over the area and constriction and expansion of the ciliary muscles and opening of outflow pathways. And you can see with the video here that it actually shrinks down and creates what Dr. Johnstone refers to as a pilocarpine-like effect. So in short, ciliary muscle shortens, the scleral spur moves inward and posteriorly, trabecular meshwork inward along with Schlemm's canal enlarging. This allows for increased conventional outflow. This will come into place as the entire title of the study is, why should we be doing this before incisional surgery? So there is some necrosis to the ciliary body and destruction and decrease in aqueous production as we see with the continuous wave, but much less. This laser, however, works through the conventional outflow pathway. There's multitude of studies to show significant efficacy of this laser over multiple years. I think the longest study was about 3 years with proven efficacy and significant decrease in intraocular pressure. Our own data at Cook County Health shows significant decrease in intraocular pressure up to a year with the laser being used as a primary treatment. This is all of these patients had no prior incisional surgery. We went on to take that our long list of data and look at, does it work as a second time? So the patient had that as a primary treatment, and the primary treatment lasted for a little while, and then the effects subsided. And so we retreated, and we saw efficacy out to 6 months, at least as far as this data showed back in 2018. It also works for secondary open-angle glaucoma, pigment dispersion, pseudoexfoliation, et cetera, quite well. So the company, due to some variability with the outcomes, decided to come out with the revised MicroPulse P3 probe, which you can see in the upper left. It's the top one in the bottom right. The probe has a much thinner shaft, a much better designed ocular interface, being that it has a cupping to it as opposed to a flat and somewhat curved surface of the original probe. The bunny ears, as we can see in this probe, go towards the limbus, and it's actually held at the limbus as opposed to the previous probe, which we attempted to, we wanted treatment about 1 millimeter or 2 posterior to the limbus, so it was somewhat difficult, and there was not always the same treatment per patient. The revised probe itself, there's less variability in the treatment, easier probe placement because of the smaller shaft, easier to get it under a lid, tight orbit, and no need for posterior treatment as we did with the original probe, and better in patients with tight lids. How do we do it? Now, this has been a bit of, it's taken a bit of working through since the release of or the pre-release of the probe, and we've come up with a very good treatment parameters, I believe. Currently, right now, we've been treating between 60 and 100 seconds per hemisphere with a 31.3% duty cycle and 2,500 milliwatts as the power output. The position is at the limbus, unlike the previous probe, which you would want to treat a little bit more posterior, and the curved edge is towards the limbus, which is much more intuitive. When we're talking about efficacy and success, I think, and we'll get into it in just a second, one of the more important things is actually sweeping the probe at a slower pace. Initially, you would just sweep it at whatever pace you felt, where I'm talking back into 2015. And then we started realizing that the speed at which you are moving this probe is actually a very important parameter, most commonly referred to as dwell time. And you can think of it as, if I have a candle and I quickly swing my finger through it, my finger won't get burnt. The slower and slower that I go, the more energy my finger absorbs, and slower in this case seems to be better. Lid speculum, there's some people that don't use a lid speculum currently. I still do. It's just easier and much better exposure. But with this new probe, it's actually pretty easy to do it without it if you so choose. So again, what parameters do we use? What optimizes our outcomes here? This is one of the newer studies from Dr. Grippo looking at fluence. There's studies to show that total energy input into the eye increases your intraocular pressure reduction. Energy period, Dr. Radcliffe looking at 2,000, 2,100, 2,250, 2,500, et cetera. There's also studies looking at the time, showing that as you increase time, you increase your efficacy. But Dr. Grippo looked at fluence, which takes into account most of the parameters, including the dwell time. It was the first one, to my knowledge, that showed in this, he calls it sweep velocity, and showed that decreasing your sweep velocity, so slower sweeps, more energy input into the eye, increased your efficacy of the treatment. And in this study, it was 52.4 centimeters squared, joules per centimeter squared was the treatment. So actually looking at the amount of energy over the area that's treated. So this is just a quick video to kind of run through. I think that a lot of the people that are on this call have already used the probe, but we'll just turn that down a little bit. So placing the lid speculum, and we'll get through it in a second, but I really do advocate for doing these procedures in general in a patient in the operating room with anesthesia. We did a study in lasers in medicine that showed that there is a significant decrease in laser output without a coupling mechanism. So I highly recommend using, in this case, lidocaine gel, Pure Lube, whatever, Goniosol, whatever you prefer. So there we're treating the patient. This was a little bit of an earlier one, and I believe we're doing a 10-second sweep here, but going back and forth with the probe held at the limbus, treating essentially like the original probe, but as you can see, much easier to get to your treatment site. Patient selection. So we went over the mechanism of action earlier, and Dr. Johnstone eloquently showed that there is an increase in conventional outflow. Given that, it can be considered in any stage of optic nerve disease, but maybe earlier in the disease in general. And when I speak of earlier in the disease, I mean somebody that hasn't had 15 years of aqueous suppression, just as we know with a cyclodialysis cleft. When the trabecular meshwork and conventional outflow is not used for a long period of time, it starts to become non-functional. The cyclodialysis cleft closes and the pressure goes very high because the trabecular meshwork is non-functional. Just in this case, if we're suppressing aqueous for long periods of time, then maybe there's scarring downstream of the trabecular meshwork, Schlemm's canal, collector channels, et cetera. So it should be considered earlier in the disease process, just as I'm a very big advocate for trabeculoplasty, not along the scope of this talk, but early in the disease process to open up the actual conventional outflow. It can be used as an alternative to incisional surgery in patients who have failed medical treatment. Again, if we're doing incisional surgery and our outflow is through a tube shunt or the trabeculectomy, well, we're not using the trabecular meshwork and conventional outflow for long periods of time. So maybe we should be thinking about this much earlier in the disease process. Not along the lines of this talk once again, but it can be used after incisional surgery with suboptimal outcomes. I do use it in patients with neovascular glaucoma at times. I'm careful with patients with vitreous hemorrhage, but there have been multiple studies showing a little bit of a lower success rate, as I think one can imagine, given the mechanism of action that the trabecular meshwork in those cases tends to not be very functional. But it can be used as a little bit of an ability to buy yourself some time for the anti-VEGF to take some effect. Anesthesia. So as I said before, this can be done in a clinic, minor room setting, but I would highly recommend, if you're not doing any type of IV anesthesia, to do a retro or peribulbar block. I personally do it in the operating room as much as I can. Patients that need a retreatment down the road tend to have a much better experience. I do it completely without a block. The patients also then don't need a patch or a shield or anything. They go home using their eyes as soon as they leave. They're a little bit blurry, but overall, most patients return to their preoperative vision within the next 24 hours. It's especially helpful in a patient that's monocular, which I tend to see a pretty large amount. Postoperative treatment, I don't recommend atropine. I started in 2015 using atropine on all of these patients and found that as many of you, I'm sure, are aware, it blurs the patients, they're upset, and slowly but surely, due to the low amount of inflammation that you see postoperatively, I stopped using it, and I haven't had any complaints since, as far as increased pain or issues with posterior synechiae. So I personally don't recommend it. The prednisolone, we've gone from a standard 4-week taper to less and less over the years. And right now I just do a standard twice every 2 days I tapered. So 3 for 2 days, 2 for 2 days, and 1 for 2 days, and then stop it. And generally my patients are off their steroid by week 1. And rarely do I ever have to do any more of a prolonged course. And then the IOP drops, I personally continue them and then taper them according to my week 1 exam. Most patients have a lower pressure at day 1 if you're checking them then. Week 1 is a bit more telling as far as your success rate, but I just tend to continue them for a little bit in case the ciliary body was stunned and you have a lower pressure than what you will eventually get at month 1, month 2, et cetera. So I'm just going to kind of go through a couple of clinical cases, and then we're going to hear a couple more talks here. So 63-year-old Nigerian woman with combined mechanism glaucoma, known well to our clinic, regularly scheduled for follow-up. She underwent an LPI for narrow angles and slightly elevated pressure 5 years ago in our clinic. Ended up actually needing some drop coverage over the next few years. The patient's 20/50 and 20/40 with correction, pressures of 24 and 20. She's only on latanoprost and dorzolamide, but has a history of follicular conjunctivitis with bromonidine and severe asthma. So we are actually pretty much maximized at this point. So the patient's above goal. Depth was moderate, quiet. The patent LPIs are noted. The patient does have a significant nuclear sclerosis and a little bit more cupping in that right eye with the higher pressure. You can see the visual fields here. The right eye may have a little bit of a subtle nasal step. Possibly the field wasn't of the best quality, but the left eye is full. So earlier glaucoma as far as the nerve damage. So we discussed options for the patient: trabeculectomy with mitomycin C, cataract extraction plus or minus MIGS. I know a lot of people probably listening would think for this patient, a cataract extraction would be a pretty good option. And in fact, in this patient, I said, why don't we just take your cataracts out? You don't see well, you have 20/50 vision. It'll help the pressure. She just wanted nothing to do with it. She had no interest whatsoever in any type of incisional surgery and was happy with her vision. So after further discussion, we said, well, why don't we try a MicroPulse TLT? We did in the OR with anesthesia. The treatment was at 2,500 milliwatts, standard duty cycle, 60 seconds per hemisphere, and the 20-second sweeps, as I said, that help increase your fluence. Patient had very little inflammation. Post-operatively was tapered off the steroids without issues. She has maintained pressure, and I actually just was going through these slides and updated it a little bit. She was seen about 3 or 4 weeks ago at post-op month 7 and still is at a pressure of 15. She's still taking the latanoprost and the dorzolamide, but the Humphrey visual fields remain stable, and I would consider it a significant success in this patient. Another patient of mine, a 34-year-old African-American male with a very aggressive family history of glaucoma. Multiple of her family members are well known to our service, and several of them have undergone incisional surgery and have blindness also. But the patient was being seen by an optical shop outside and told that he had glaucoma and he should come in. He's 20/30 in both eyes, pressure 32 and 36 on arrival. That's untreated. But again, in this 34-year-old male, 0.95s with extremely thin rims in both eyes, slightly thick packies, which is helpful, but obviously this patient needs a lower pressure. You can see significant thinning on the OCT. And this is this gentleman's 24-2s. The 10-2s show very, very little visual field, but again, he's 20/30. So started him on Diamox and pressure drops, came down to 22. I, at this point in time, this was a few years back, said we really need to do a trabeculectomy. You're going blind. And he absolutely refused. The patient has a career as an actor, actually, and he just could not have the cosmetic outcome of a trabeculectomy. He researched himself and brought up the idea of a trabeculoplasty, and against my better judgment, I said, okay, fine, we'll try a trabeculoplasty in the right eye. And sure enough, on a Friday afternoon, I did the trabeculoplasty. He shot up to 27. My fear was that the pressure was creeping up higher and higher. So I, with much upset to my own judgment, had to see him on Saturday morning. And luckily, the pressure spike amounted to not too much, and he came back down to the 22 that he was previously. So after a long discussion, we did the MicroPulse, 160 seconds. This was back when we did a little lower treatment at the 2000 milliwatts. But this patient did extremely well. As you can see on the right corner, he did get off the Diamox, but he still maintained on his pressure drops, remained deep and quiet for 10 months plus of low pressures, and he's still sitting in the low teens range. All right, well, that's the end of my section. Just to let everybody know, if you have any questions, please post them in the question and answer. Some of them we'll answer at the end, but some of them I'll try my best to kind of throw in a little bit of text answers as we need to. So I'd like to introduce Dr. Ahad Mahootchi. He is based in Tampa, Florida. He has been in practice for 25 years. He's one of the first MicroPulse TLT users in the US. He has 6 years of experience with over 500 cases performed. I've had the pleasure of meeting him. He's a wonderful guy, and look forward to hearing what you have to say, Dr. Mahootchi.
All right. Thanks, Michael. I appreciate it. And thanks, Iridex and Mona, for joining us or for putting this on. MicroPulse TLT is treatment before incisional procedures. I'm probably going to show you some different kind of cases. My experience has been mainly with earlier cases. I used to do about 30 trabs a year. I've been thinking over some time that some of the stuff that you learn in residency about how you treat patients before you go to surgery often can determine success or whether you even need to go at all. So I think it's a good idea to think about things earlier. So I think it's important to realize that glaucoma doesn't really have to look like this. I think we've become accustomed seeing patients with red eyes, with the zombie look in the office. And that's kind of what we're used to thinking is normal. And that really isn't the case. Patients we get the droopy lid, the ptosis, the fat loss, and I think we can really do a lot better. My primary use is to reduce the drops, and we just on the previous presentation with Michael was reducing the pressure. I've noticed that in a lot of people, there's other studies that say that patients on 3 drops are likely to fail. So I don't like to play all my drop cards too early. And I think if you lessen the conjunctival exposure to drops, you make the next step more likely to succeed, especially if it's filtering surgery. You're just inviting macrophages and activating fibroblasts to make your flow through whatever incision you have less by the number of drops and the time that you've exposed them. So less drops also means less expense to the patients, and MicroPulse is certainly a less expensive alternative than many other glaucoma surgeries. It's certainly low morbidity and good efficacy. In my experience, in the first 300, 92% were either on less drops or lower pressure or both in the first 6 months. And it really, it diminished a little bit over time, but not much. It was 85 at 2 years and something like 70 at 3 years. So there's no real downtime. I agree that there's a lot of different ways you can do it, but there's some pretty cool things you can do in the OR without blocking that can allow you to do one eye or both eyes, or and allow people to recover very, very quickly. And I certainly know in my experience, the effect seems to last about 3 years. So again, my goal is, to use less drops or to have a lower pressure or both. If you're looking for a low pressure period, not a lower pressure, but low pressure, I find it useful to combine cyclo or TLT with goniotomy or even other procedures to get a low pressure. It can be additive with other things. So I like to think 1 drop, 2 drops, and then MicroPulse TLT. I generally, unless you're going to your daughter's wedding, I don't let you stay on 3 drops very long. And it's important to think about that we're seeing patients at a younger age, we're diagnosing things at a younger age, and patients are living longer. So that time exposure to drops and ultimately things that might make you fail is longer. And so, having non-incisional laser options that spare conjunctiva really give you a valuable addition to the new treatments of a new treatment paradigm of adding more time without surgery or more time without incisional surgery to the longer patient's life. So here's the device. Again, it's non-incisional, fast to perform, minimal inflammation, just like Michael said. That's been my experience. And you could combine it with other procedures. You can do it on one eye or two eye. It's conjunctival sparing, which is a big deal to us in the glaucoma world. It leaves future options open. You haven't really scorched the earth for your next adventure if you need one. And it's definitely got a much more broad use than end-stage glaucoma. I'm in private practice, and my patients are probably nothing like the two university-based physicians talking today. But it's just useful at a much earlier stage. So, the advantages are, again, non-incisional, strong safety profile. It doesn't preclude other activities or other procedures. There's no restriction on the activities. The quick visual recovery, I'll just show you in the next slide of a great patient I have. Less frequent post-ops, and if your visual field's not terrible and you're just trying to reduce the pressure or drops, I have just do the procedure and I see them actually 5 weeks later. I started seeing them early on. And if they have a terrible visual field or things are sketchy, I don't do that. But if you're just trying to get somebody with a pretty good visual field on less drops and a lower pressure, this is the way to do it without really costing a lot of post-op time. I think there's really no risk of infection with this. It's quick, 2 or 3 minutes per eye, and you can do it in the office. I know some who just use lidocaine gel but let it sit for a very long time. I prefer to get people kind of in and out. So this is a repeatable procedure. I typically, one of the things I think with the magic of anesthesia is you don't have to use very much. You don't want to give them a lot so that they're in post-op for a long time. Your nurses will hate you. But we use just a little bit of Versed before they go in the room and a little bit of propofol, much less than what you use in a colonoscopy, and a little bit of fentanyl. And they're out, you do the procedure, and they wake up and they say amazing things like this.
No, you've done something already?
Yeah, we're already done with it.
Oh, I didn't know that.
That's great. So didn't feel it, didn't.
So, she's 10 minutes after the procedure and she's seeing it, doesn't even know anything's been done. Can't tell anything's been done with her vision. So by her vision. So again, you can do it with a block, but you don't have to. You can do IV sedation. Can do it by itself, bilaterally with cataract surgery. Often, if I see somebody I'm doing a ptosis repair on, if they've, there's no point in leaving them on the prostaglandin analog, it's going to come back. So you can do cyclin G6 even with your blepharoplasties if you're a general guy or doing those kind of things. So anyone works with pretty much every kind of glaucoma, whether it's open angle, ocular hypertension, low tension, chronic angle closure. It's the mechanism, as we saw earlier, would apply to all those different things. So my usual post-op for generally earlier patients earlier with mild or moderate disease is, there's no hypotony or pressure spikes or significant inflammation. I usually don't see the patient on post-op day one. I stop one med at week one, and I use TID steroid for 2 weeks, but I might adopt Dr. Giovinco's technique of stopping it maybe at 1 week. I usually use loteprednol so I don't confuse steroid response with the ultimate outcome if they somehow manage to use the drop longer than I want. I typically see what I'm going to see, which is 92% of people are responders at 5 weeks. If I see them at 3 weeks, 80% of patients are responders. So I usually just see them at 5 weeks unless they're high risk. It's easy, but it's not that easy. You don't want to make up your own technique. You want to video yourself and review your own technique. You'll be your own worst critic. And you'll see how you oppose the globe, keeping the tip underwater, all the different things. Your MicroPulse, Iridex will give you a nice card of the things, how to do it right. And you should know how to do it wrong and don't do it that way. The speed seems to be the thing you want to vary. Don't play with the duty cycle. I wouldn't play with the power too much or at all. It's how fast you're going with the device. You can go too fast and you're probably not doing very much. I do it usually in a 15-second per hemisphere, but I mean, 20 is the latest recommendation. And that's really probably where you should start. I don't really vary the power ever. And I think you really, when you're doing this, you want to look at your results first, at least 10 cases, and before you make any changes. So, the TLT with the MicroPulse P3 probe is what we're talking about. The mechanism of action is probably multifactorial. I don't think we completely know the whole story of how it works, but it's probably a little bit of inflow and outflow effect. And it's not cyclodestructive light. I think that the amount of inflammation or chances of getting CME or chances of having anything really bad happen are very, very, very small. It's very safe. And that's because if you don't already know, the power is on for less time than than what the tissue needs to have to sustain damage. So you're doing something, but you're not irreversibly damaging the tissue. So again, this is the new probe. That's quite a bit different from before. The laser delivery pipe, you can see, is recessed as opposed to bulging out on the last model. The rabbit ears are on the limbus, and that's where it is. And you'd be surprised at how much it wobbles a little bit. And a little wobble is probably not too bad. You can get to treat different areas of the ciliary body, but you really want to stay pretty much here. Go too much anterior, you might get some iris changes. You go too far posterior, probably not doing much or creating some inflammatory stuff in the retina. This is probably the key and I think, again, videoing yourself and how often do you stay in this position for the whole 180-degree sweep, times 2 is a big deal. You have to learn to hold it like this. It's not tangent to the, or it's not perpendicular to the surface. It's at this angle because of the curved foot plates. So the new probe does make it easier. I don't use a speculum. I kind of find it harder to use, but you can do it either way. This does match this globe surface much better than the last probe. Don't seem to have to worry as much about keeping it under fluid, but you don't want to lose energy to probe air interfaces. So, it's kind of easy to match up the limbus and the eye, and it's kind of easier to sweep. And you need to, rotate your finger a little bit as you're rotating to maintain that perpendicular to the limbus posture that you want. So that's what you're doing. You could do it in quadrants. Sometimes when it's a tight quadrant, you might need to do that. Obviously, the inferior is easier to treat than the superior most of the time. Sometimes I'll take a Q-tip and put it in an inferior fornix and rotate the eye down if I'm having trouble getting enough space under the upper eyelid. Hats off to Iridex for figuring out how much energy is actually delivered. And I think the bottom line is, we've got this fast sweep and you're not really doing too much about delivering energy. In the 20-minute sweep, you're delivering about just right, and you don't want to do too much. So don't hold it in one spot and press the pedal. Bad things happen when you do that. It's the 2,500 milliwatts is the power you want to use. And I do 15, but most people use 20 seconds per hemisphere. So here's a case of mine. We'll just do one of mine before we get to Mona's. But it's a 73-year-old white male who is unhappy. And in 2015, they were on 2 drops for their glaucoma with a pressure of 18. Early 2016, I do cataract surgery with eye stent. By late 2016, he's 1 drop instead of 2. His IOP is 16, but it's been creeping up from his 13 post-op. By 2017, it's all the way back up to 19, and he's underwhelmed. Why did I pay extra for that glaucoma stent, doctor? So I added the 2nd drop back, and his pulse starts to slow. So 2018, I do the MicroPulse TLT, and 5 weeks later, he's 13 on 1 drop. And I haven't tried to stop the last drop yet, but I just saw him, and he's 3 years out, and he's still 13. So I'm happy I haven't had to do anything incisional. I haven't done to do a Zen on him. I haven't had to do other things, but he had previously not responded to laser trabeculoplasty and wasn't, there were contraindications to the drop. So your patients, if you've been in practice for a while, you'll have many people who have been allergic to bromonidine or become intolerant to betamol or don't like the cosmesis or of the prostaglandin analog. So this is just another tool in your tool belt to be successful and have everything you need to offer to your patients. So that's all I have to say. I'll stop sharing my screen.
All right. Well, thank you very much for that talk, Dr. Mahootchi. I'm now going to have the pleasure of introducing Dr. Mona Kaleem. Dr. Kaleem is an associate professor of ophthalmology at the Wilmer Eye Institute, Johns Hopkins University in Maryland. She serves in leadership roles in the American Glaucoma Society and the World Glaucoma Association. In 2020, she received the Achievement Award from the American Academy of Ophthalmology for her work. She was one of the first MicroPulse TLT users in the United States, and look forward to hearing what she has to say about this topic.
All right, it's great to be here with everyone tonight. I'm very excited to share with you how the MicroPulse has really transformed my practice and helped me to give a lot of great options to patients. I've been doing the MicroPulse since 2015, and nowadays I'm probably doing 1 to 2 cases per week. I'm a surgeon who does all of your trads, tubes, MIGs, and this. And the way that I practice glaucoma is I like to give patients their options. I tell them what are the different things you could potentially have, what is the target pressure for you. And I will tell you that a lot of my patients are excited about the MicroPulse as an option for them. And I also treat people at all disease stages from early to advanced, people who come from all walks of life, who have had nothing done to their eye or have had everything done to their eye. And they're usually coming to me for a second or third opinion. And again, this has been a really popular choice for many patients. So it's also great that the MicroPulse has been around since 2015. It's available in 80 countries and has helped around 150,000 people to date. I'm just going to give a summary of how I do this procedure and how I like to practice this with my patients. With regards to the MicroPulse, it's a very versatile procedure. It can be done really anywhere. It can be done in the clinic, in the minor procedures room, in the operating room, or even at the bedside. Let's say that you get called for a consult at a hospital and you need to do this procedure for someone because their pressure is just too high. They cannot go to the operating room. They cannot tolerate eye drops. You can simply just transport the laser box and the probes to the bedside and do the procedure for them. Again, it can be done in the minor procedures room. And I usually like to do the procedure in the operating room because I like to give the option of having IV sedation. You can simply just put this laser in a suitcase, take it around with you wherever you need to go. This is a really great option if you're someone who practices maybe in a remote area, or maybe it's hard for you with your surgery center to purchase one of these and you want to have it as part of your practice. Again, you can just simply move it around with you. And if you're traveling to remote sites, maybe you're in a different country where there's not a lot of access to glaucoma surgery, or you're here in the United States, and you can just take this with you to any practice you go to. Bilateral cases are an option, unlike usually with incisional surgery. So you can do a bilateral MicroPulse on a patient in 1 day. It's a non-sterile procedure, so there's really no risk of an infection. Also, you don't need to use sterile gloves. You don't need to use antibiotics after the procedure. And certainly the risk of causing, again, any kind of an infection is really not there because there's no incisions in the eye. One thing that's been really great for my practice is the referrals that I get for MicroPulse. So as I mentioned, I get many second, third opinions. And with regards to referral, because we have the MicroPulse, I do get many patients sent to me for that procedure in particular. So it's a great thing to have in your surgery center or with you in your practice. It's also great for co-managing patients. Let's say you work with an optometrist or another kind of an ophthalmologist, like a comprehensive ophthalmologist or cornea specialist who sends you patients, and they want to see the patient back in the early postoperative period. You can simply just send the patient back. I generally see the patients 1 week and 1 month after the procedure. I think just a 1 week visit with the surgeon would be fine. Or if in your practice you want to send them to the referring doctor even sooner, that is just fine also. Whenever I think about which glaucoma surgery or procedure I'm going to do, I think very carefully about what's the eye pressure target for this patient. What is their baseline visual acuity? Are they seeing on the chart or are they not seeing on the chart? What is their disease stage? And usually their disease stage also helps me guide what target pressure they should be at. Also, what kind of a glaucoma do they have? And it's very important to know what comorbidities patients have. If they are sickly and not good surgical candidates, then they're not good surgical candidates. They're much better MicroPulse or laser candidates. Let's say they have issues with transportation. Maybe they live alone, they don't have a great social support system. They have a hard time using drops, whether that's before a procedure or even post-operatively. There are several patients I have many concerns about their ability to comply with post-operative instructions. And that helps to me to guide which procedure I'm going to offer them. If I think someone is at risk for an infection or having a complication from a trab, a tube, or one of the mixed procedures, I will not do it for them. I will offer them the MicroPulse. And also think about if you have to do urgent cases or routine cases. Certainly you can sign your patients up for routine cases to do this. But let's say you're the only glaucoma surgeon in your practice or the only person in the area that has the ability to do the MicroPulse and you need to do something pretty urgently, or maybe your surgery schedule is booked up for months. You can easily fit in a MicroPulse procedure that needs to be done. It is a very short time that we need to block off in our OR, or again, something you can simply just do in the office. There are not a lot of contraindications for the MicroPulse. I think one of my favorite applications for this procedure is actually in patients who have a cornea transplant. Either they've had the transplant or they're preparing for a transplant. So in patients who have had a transplant, and they have glaucoma, I think a lot about, well, if I'm going to do a tube shunt, I'm putting something in their eye that can make their cornea transplant get worse. So why would I put a patient at that risk if I didn't have to? I could put the tube in the first plana, but of course that also involves its own set of risks. So I think that doing MicroPulse in patients who have had these cornea transplants or DSECs is actually a very good option. It's been a big part of my own practice. And there have been reports in our literature, there have been retrospective studies that have looked at the rates of corneal disease or graft failure after a MicroPulse. That rate is very low. The patients who do tend to have graft failure after a MicroPulse are the ones who start out with a very low endothelial cell count. It would be nice to check endothelial cell count. I think that we're still learning lots of things about this procedure as we go along, but that is my 2 cents. And again, something that I really like to do for these patients as they are post-transplant or also getting ready to do a cornea transplant. I will go ahead and do the MicroPulse a few months before they're getting ready for their cornea surgery. You have to be very careful in your patients who have a history of macular disease. If they're prone to cystoid macular edema, then be very careful. Usually if I'm going to do this procedure for patients in that situation, I'll think very hard about whether they're truly a good candidate. However, if I am going to do the MicroPulse in someone who's at risk for CME, I will always obtain a pre-laser OCT and a post-laser OCT. I will tell you how I treat them to get them ready for the procedure. And also the fact that they have these conditions, maybe a risk factor for corneal edema or CME, also helps to guide how many quadrants I will treat in their eye. And I do the quadrant technique. So the MicroPulse really has a good safety profile. It's not as inflammatory as some other conditions. I'm going to hone in on that point, no risk of an infection, and there's a much shorter downtime and fewer restrictions. So people can fly, they can go about their normal activities like working or whatever it is, really just the day after the procedure. I would be careful in patients who are at risk for neurotrophic keratopathy. So this is something really important I want to point out for all of you. So if you have a patient who is in this situation, I would heavily advise you to stay away, of course, from the 3 and the 9 o'clock position. You should consider treating your patients postoperatively with aggressive lubrication. And also, I find that the patients who develop the neurotrophic keratopathy, in addition to having risk factors for dry eye and corneal disease, if the treatment is done a little bit too anterior on the limbus, then that obviously can be an issue. So I advise all of you to stay a little bit back from the limbus when you're doing the treatment. And again, think about how many quadrants or hemispheres you want to treat. I don't always do the entire eye. Sometimes I just do half of an eye or 3/4 of an eye. I've kind of developed my own technique over time based on things that I have seen. I'm just going to go over how I do the procedure. So pre-operatively, I'll tell patients to stop medications that can cause subconjunctival bleeding. So there are certain medications, again, that can cause that, or things that predispose them to that situation. What happens with hemorrhaging is that it gets the laser energy is absorbed by heme. So we want to try to prevent that from happening. I'll pre-treat patients with a steroid or an NSAID eye drop if they're at risk for corneal decompensation, uveitis, or CME. And in addition to that, I want to add artificial tears for patients who are at risk for neurotrophic keratopathy. Post-operatively, for all of my glaucoma procedures, I actually stop prostaglandin analog eye drops. Been doing that for a long time, and I do that because I think that PGA drops are pro-inflammatory. Some people could argue with me about that, but that's what I practice. That's what I believe. With regards to the post-operative regimen with steroids, I taper the steroids over about a month. I start out with Pred, Forte, QID, or sometimes FML or Lotamax. Something really interesting I learned from my Wilmer colleague, Dr. Jawan, is about doing subconjunctival dexamethasone and tapering prednisone over 1 week. So I think I'm going to try that. And that comment has also been made earlier in this talk. So I'm actually interested in trying to taper patients off of the prednisone faster. I do use atropine twice a day for the first 3 days. Again, that's to try to prevent or to reduce the risk of any inflammation and to quiet the eye and also prevent any pain. Ocular lubrication for those at risk, again, for neurotrophic keratopathy is very important. I'm really honing in on that for a reason because I've seen it a few times. And if someone needs to be retreated, think about titrating the quadrants and hemispheres. I would say that we're pretty well established with the power that we're using, but things you can alter are the area that you treat and your sweet speed. My technique is the quadrant technique. I like this because I have a smaller hand. I think it's easier for me to keep the probe on the eye when I do things in quadrants. And when I do this quadrant technique, I do 6 sweeps and they're 10 seconds each. So I make 6 passes or 3 round trips over each quadrant. I use lidocaine jelly or Gongasol, really whatever is available. And I do like to use an eyelid speculum for the patients, but it's not really required. I don't really like to use forceps to hold the eye. I generally like to use a Q-tip because if you use forceps, you could induce a subconjunctival hemorrhage. That's happened to me. I use a very diffuse light and I elevate the patients up. Some people like to use a microscope. I like to stand up when I do the procedure and I like to bring the patient up so that I'm not hunched down. And I do like to do a retrobulbar block. I'm very comfortable doing retrobulbar blocks, but obviously not everyone can have that. So for those patients who are at risk for a hemorrhage, I will do a peribulbar block. I'll also do a peribulbar block for patients who are monocular, and I'm doing the treatment on that eye for them that day. And I'd rather give an injectable anesthetic for my patients because I have I've gotten a few calls in the middle of the night from patients who had pain. I would really much rather just try to prevent that. I rarely get phone calls from patients anymore after this procedure. Another nice thing about it. Again, we know that the recommended power is 2,500 milliwatts, and that's pretty well established. I think that we're looking for more guidance on the sweep speed velocity, the number of sweeps, the degrees of treatment, and that information is pending. I'm actually going to be looking into that myself. And just a few case examples. I will not take up too much time, but just a few of my own patients. A patient I'd mentioned earlier, the cornea transplant patients. This woman had a DSAC. She had a steroid responsive glaucoma. She did not want to go to the operating room. I did the MicroPulse for her in the minor procedures room, and 1 year out, she's doing well with a pressure of 12, and she's just down to 1 medication. She's happy with that. When I talk to patients about this procedure, I tell them, you probably won't be drop free, but I think I can get you down by 1 drop or maybe more. And that treatment effect should last at least 1 year and maybe more than that. You might need more than 1 treatment. Again, we may not be able to take you all of your drops, but you could potentially avoid having a big surgery or delay the time for that surgery. And that's something that people tend to really like. Another patient, 93 years old. She has a history of getting intravitreal injections and glaucoma from that. She has count finger vision in both eyes and is not able to comply with a post-op regimen for incisional surgery. I did the MicroPulse for her. She is drop-free at 1 year. And my last patient, I wanted to discuss a gentleman who works in politics. My practice is right outside of Washington, D.C. And so this person, he does not want to be on any drops. He does not want to have any surgeries. And I did the MicroPulse for him in the operating room, and he's drop-free as well at 1 year. All right, thank you so very much. If any of you have questions, please feel free to ask them now. You can always email me. This is my email address. And thank you again for letting me speak tonight. I hope that you will try this procedure in your practice. It's really helped me a lot. Thank you.
Thank you, Dr. Kaleem and Dr. Mahootchi. Excellent talks. Now I think we have a few minutes to just do a couple of quick questions. I think I've kind of done most of the answers directly, but we can throw a few of these out there and see what you guys think as well. So it's just kind of an interesting one for both of you and myself. What was your wow moment with MicroPulse TLT?
For me, it was being able to do it at the bedside on patients in the hospital. I work in an academic practice, and some of my patients are very sick. Just being able to roll that in the room and do the procedure for them and save them a tube shunt.
I think for me, it was the speed of recovery, just seeing the people, not it didn't have the morbidity of other procedures, and it still had more bang for the buck than say laser trabeculoplasty, but it was just nice to see them recover so quickly. For me, and then looking up just 3 years later, seeing how many were still doing well was a big deal.
Totally, I agree. The one thing that for me kind of was a wow moment was the fact that these patients that are fearful of getting a trabeculectomy that are monocular, the 2020 patients that are, they don't want to wake up the next day blind, and they're, they next day are hugging me. They're like, wow, I still see, I'm still functional. Amazing procedure. So let's see here. We got a couple more pouring in. Do you change the parameters depending on iris color?
I don't.
Dr. Kaleem?
No, there's no data to suggest that we should be altering treatment parameters based on iris color. I do not do that.
Yeah, myself, we've been increasing the parameters to try to optimize the outcomes, but no, most of my patients as a FYI or public service, most of my patients are African-American and Hispanics. So I have mostly heavily pigmented individuals, but I don't see any need to change it myself, at least in my practice. Okay. Could you discuss your experience of MicroPulse in patients who have borderline IOPs after valves or traps?
Mona, I'll let you go first.
So I get a lot of those, and it really depends on the patient, but I've been happy with my outcome so far in doing MicroPulse after a tube or a trab. And it really doesn't matter what kind of a tube it is. But of course, I'll always avoid going over the area of the trabeculectomy or going directly over a tube shunt when I'm moving the probe, just to avoid any risk of exposure of the tube or any kind of a perforation or blood leak or anything like that. I have not experienced greater complication either from that. Sorry.
No, I agree. If you've done a trab on somebody and 10 years have gone by and your goal was 14 or less, and they were there for a long time, they've gone up to 19 or 20, this is your chance to get it back down. They probably don't want to do another trab again. They remember they were intolerant to all these other things. So don't prove they're bromonidine allergic all over again. Just do this and call it a day. And it really is nice. It's additive with other procedures, but it's also additive years after the other procedure. And it's, again, before you do another incisional surgery, this is your chance to success. I think there was another question about somebody, if you don't have a terrible field, but you've got, you're on 4 medications, but the eye's all red, you might do yourself a favor by getting the 4 medicines down to 2, let the conj quiet down, and then do your Zen, trab, or tube under less duress. And your chances are you're gonna do yourself a favor by getting your success rate in one shot a lot better. Although you're using Cyclo G6, I mean the TLT to MicroPulse TLT as your tool to get there.
Yeah, totally. The one thing I think that needs to be taken into account with this is whether or not your previous incisional surgery has failed or it is partially functional. So a tube that's gotten me down to the high teens, low 20s, in a patient who was previously 36, is the MP TLT just kind of adding that extra little bit of oomph, a little bit of ciliary body destruction, a little bit of outflow to get me down into the range that I need to. And we've got pretty significant data showing I think we're in the last I checked was in the 60 to 70% success rate as far as lowering the pressure after tube shunts. Trabs are a little bit of a different bird, in my opinion, because a lot of times they're failed, and that whole area is scarred. But I think they work extremely well after tube shunts. Okay.
I did want to mention one thing to consider also for those who are doing a non-valve shunt, like a barbell or a clear path. In that early period before the shunt opens and the vitral dissolves, a lot of people are looking for options to lower the pressure in those first 6 weeks. And so I think that a MicroPulse laser could be used to treat that early hypertensive phase.
Okay, so another question. This is actually a really good one that I've been, posed to by a lot of colleagues. So, just to paraphrase the question, the MicroPulse TLT is, being talked about so much here. Do you guys still use the G probe? Do you think it has a place in the treatment algorithm? Do you think, take it from there?
I don't have that many severe cases, so I'm not. I really have to use that, but it's not been in my armamentarium. I've used it on it a couple of times, and it was great. But you guys probably see many more that might need to do that.
Yeah, I still do a lot of G probe treatments. So.
Yeah, I find it indispensable in a lot of cases. The patients that have patients that have failed MPTLT multiple times that I just can't get the pressure down, I do think it's more efficacious. It's much higher risk of CME and hypotony, much more inflammation. But in patients that you just can't get them down with other means, and the ones that I really think it's helpful in is somebody who's had heavy anterior segment scarring, somebody with neovascular glaucoma, somebody with multiple corneal transplants, anterior segment scarring for whatever reason. I did one recently on a K-Pro. I think that it still has a good place in the glaucoma armamentarium. Let's see here. Okay, I think we're probably winding down. Let's see. The total energy from the Iridex has been suggested to be 157, which is 100 seconds per hemisphere. Is your standard total energy? Is this your standard total energy currently? So honestly, I don't even know in joules what I'm using to do without the calculation in front of me. Personally, I've been just going by the increasing the fluence by decreasing my dwell time, or slowing down my dwell time, I guess I would put that. I don't know if anybody else has any input as far as the joules that they use.
I don't.
Never go above 200 joules, but stay in that 150 range.
And then the only other one still up there was what kind of anesthesia do you use for treating children? My personal take on it is I get a pediatric anesthesiologist and I let them deal with it. I don't have much experience with it when I've needed to.
I've done a couple of pediatric cases with a MicroPulse. They're patients who have had other incisional surgeries, and they're still doing well.
Awesome. Great. Well, I think that is the total of the questions. Thank you all very much for joining us tonight, and I hope that it was very helpful to everybody. And we can, we'll hang out and I'll keep an eye on the question and answer for a minute. I'm being asked to make sure that everybody's aware that that the webinars about using MicroPulse in combination with or after or glaucoma procedures are all available at iridex.com/webinars. I'm very glad to have listened to all the talks, and it was great to hear everything from everybody. And I hope you all have a good night and stay safe. Thank you.